And the topic that was assigned to me is, what can we learn from CT procedural planning? I'm going to delve into a little bit into CMR because it's also very important for us to consider. And those are my disclosures, but a relevant one here is also that I'm quite excited to join our group here at Minneapolis Heart Institute, Paul, Richard, and many others here in the audience to start in October. So what are imaging needs for the tricuspid valve interventions? This is a great review paper that Becky also co-authored along with Joren Bags and Jonathan Leipzig, highlighting that depending on the tricuspid valve intervention that is going to take place for this patient, we need to make some measurements, which makes sense, right? So if we're going to deal with heterotopic transcatheter valves, which will be attaching to the caval to the right atrial junction, either in the SVC or in the IVC, we need to measure those distances. We need to measure what's the distance between the caval atrial junction and the first hepatic vein. It cannot be too short, otherwise it's going to obstruct that. As you heard from the prior speaker, if we're going to be doing tricuspid valve annuloplasty, we need to look at the dimensions of the tricuspid annulus as well. We need to look at the distribution and the course of the right coronary artery. And the good news is that there are a lot of software nowadays available that allows us to do the segmentation and help us with that planning. Edge-to-edge plasty is something that we'll hear later about. I would argue that for the tricuspid valve, as you heard before, because it's the largest valve that we have in the heart, actually, perhaps combination therapy, it might be something that we will probably should discuss later on as a group. Where would this fit into this therapy? Spacer as well as an involving ring, as we have now new devices that are coming out in trials. So from the CT standpoint, the data acquisition would be similar to what we do for TAVR, with obviously the highlight that the contrast acquisition should be emphasizing, enhancing more on the right ventricle than obviously the left side. So we acquire throughout the cardiac cycle images of the entire chest, just exclude the legs. There are protocols now described in the literature that are waved and EF based, because the slower the contrast and the RV dysfunction, the slower that contrast will be, and we might have more time to image. For the tricuspid annular assessment, post-processing software, as I mentioned before, that would help us out in several of these aspects in addition to the fluoroscopic angles. So we cannot talk about tricuspid valve without talking about the right ventricle. And it's early in the morning, maybe you have or have not had your breakfast. But for the left ventricle, where it's very easy to image because it's a very circular donut, the croissant-shaped RV does not help us with the image by true dimension. As you can see, this is from actually the guidelines by the American Society of Guidelines. Depending on the probe angulation, I might have an RV that looks normal in size to an RV that might look borderline. And this inaccuracy and this capability of not being able to be precise and reproducible is something that we need to borrow into cross-sectional imaging modalities. Before we go into the CT, it's important that also we put important highlights on what are the best practices to image CT for the RV and tricuspid valve. This is an important paper that I would leave with the reference to you that highlights the challenges that we have for imaging patients with tricuspid valve. One of the most common challenges is the fact that they have atrial fibrillation. Very common. It's 80+% or so. It's more common than uncommon. And so with atrial fibrillation and high heart rate, we need to deal with CT scanners that not only will provide a very extensive coverage, the more number of detectors, the higher the ZX coverage, but you have to have also temporal resolution. And what is temporal resolution? Think about temporal resolution as the shutter speed. You have this fan blowing very fast. If I need to stop the motion and be able to see each one of the colors, I have to click quite fast. For a heart rate around 70, temporal resolution should be ideally around 50 to 60 milliseconds. And the way to improve the temporal resolution, the best way is obviously to control the heart rate if you can. But if you can't, then use scanners, such as dual source CT scanners, that instead of having half of the rotation time, would be a quarter of the rotation time of the gantry. So there are developments in technology as well to help us out with that. Obviously, the CT scan requires a specific contrast injection protocols, as we mentioned. Ideally, we'd like to do a test bolus, so tracking the ascending aorta, but most of the protocols use what we call a triphasic contrast mix. A little bit more contrast than saline, a little bit less contrast than saline, and then a saline flush. And with that, we will be able to adequately opacify the right atrium and the right ventricle. This is just an example of a scan of a patient that for tricuspid valve intervention, as you can see, patients in atrial fibrillation, the scanner patients going fast fib, you do not see so well, it's blurred. And there is a lot of contrast mixing as well. This one actually was an appropriate gating, but the contrast actually was more on the left side, right on the right side. So importance to details makes a big difference. Ideally, what we would like to achieve is something like this, right? So we have a nice opacification of the right side, not so much on the left, but you can clearly see here the atrium is humongous in comparison to the right ventricle. There's incomplete cooptation of this valve. And sometimes we even see contrast refluxing all the way into the hepatic veins, which is another sign of significant tricuspid regurgitation, as you can see here. And with that, we can do the segmentation as well and calculate ejection fraction and so on and so forth. Now, what are the other anatomical aspects that also are important? Tricuspid annulus, we do this with multiplanar reformats, 4-chamber, 2-chamber, then we can derive that. Mind you that we're going to be doing this in early mid-diastole, first frame after the valve opens. We can do then the tethering and tenting area. These are parameters that have been brought from transthoracic echocardiography literature, but completely applicable to the understanding of the dynamism of the tricuspid annulus, as well as this tethering and tenting area that might be actually a predictor of recurrence or lack of complete success. We can also measure the anatomical regurgitant orifice area throughout several phases of the systolic cardiac cycle, and we can do the averaging of that. With the CT, once we segment that annulus, we can also get the angulus of implant, and with that we can do prosthesis simulation, measure the caval to right atrial junction, as well as measure the course of the RCA and the distance to the tricuspid annulus, because we don't want it to obviously cause RCA injury in a distance less than 2 millimeters or so would be considered less favorable. Now switching gears from CT to CMR, what's happening there? There's a lot happening for the right ventricle, and the right ventricle also can be beautifully imaged by CMR, actually without the need of any contrast. So for patients that are kind of borderline chronic kidney disease, I would argue that that's probably one of the best methods, because we can get images such as this one, as you can see. We can do at the 4-chamber, a 2-chamber, dedicated RV inflow and outflow view. Can look at the leaflets as well, do the same measurements. We can even do three-dimensional segmentation of the annulus, similar to what we did with CT without the need of contrast. An evaluation also of a residual RV dysfunction in tricuspid regurgitation can be done in patients with after mitral clip. As you can see, the challenge here, though, is that the atrial fibrillation. So we need to understand that this is also something, and we need to talk to industry, and we need to also be updated on what we have available. Patients that have received a defibrillator, patients that have a pacemaker, yes, we can do that. There's going to be some artifact there, but that should not preclude us from doing the measurements. And importantly, quantification of tricuspid regurgitation is something that also CMR is capable of doing, despite the pacemaker. If we go the end diastolic and systolic volume, whatever the ventricle squeezed, which was 102 mLs, should have left the pulmonic valve. When we measure the flow into the main pulmonary artery, only 42. So if you do the math, 60 mLs actually is what regurgitated back into the right atrium. And that's the tricuspid regurgitant volume. If you divide that by 102, you have a tricuspid regurgitant fraction, significant for severe tricuspid regurgitation. Now, technology, as I mentioned, continues to evolve. This is the standard way they require images for patients with CMR. Mind you, this patient is in heart failure. You can see bilateral pleural effusions, atrial fibrillation. One way that we can do, and it's available now, is do the free breathing in real time. So patient is breathing in and out, and this is almost like an echo-like. The compromise is that we're going to decrease the temporal spatial resolution. But this is also another software development now that we can average a significant number of cardiac cycles, and by doing that, now we can measure precisely the ejection fraction with that. So we cannot talk about tricuspid interventions also without talking about the right ventricle, as mentioned before, and perhaps one of the most important parameters that we should track is actually RV function and RV dilation. Patients that have tricuspid regurgitation don't die from tricuspid regurgitation. They die from RV failure and from many other things as well. It's important to intervene prior to that. And the precision of CMR, actually, it's probably very advantageous. in regards to, for example, to look at a change of only 5% on EF, MRI will require 23 patients as opposed to 51 patients by a transthoracic echocardiography, so it could be cost savings. And lots of things happening too. We can do RV strain, we can look at 4D flow, tricuspid annulus, we can track that inflow, how much comes in, how much leaves, and even looking at fibrosis of the right ventricle, which might be another important marker that we can do. So in conclusion, CT planning for tricuspid interventions requires specific protocol for acquisition, requires specific protocol for segmentation of that annulus, is also capable of doing RV volume quantification, similar to what we have shown. And then for the CMR, lots of things happening. The good news is that most of them do not require gadolinium, and we should try to consider integrating, as we are doing now for these tricuspid interventions, in borrowing from the cross-sectional imaging, particularly the combination of both modalities. Thank you very much.